The following podcast is part of a certified educational activity titled Endometrial Cancer Care in the Age of Immunotherapy, translating clinical evidence into meaningful improvements in patient outcomes across the disease continuum. Access the entire activity and complete the post-test at peerview.com/UDV860. Downloadable slides and practice aids are also available.
Hi, good evening, everybody. Thank you for joining us for Endometrial Cancer Care in the Age of Immunotherapy, translating clinical evidence into meaningful improvements in patients' outcomes across the disease continuum. I really want to welcome to the stage with myself, David O'Malley from The Ohio State University, where I lead the Division of Gynecological Oncology. Two of my great friends in GYN oncology. And I'm really honored to share the stage with you each today. Anna, can I introduce yourself?
Yeah, hello, thank you, David, for having me tonight. Good evening, all. Thank you for joining us. My name is Sana Wagner. I'm a medical oncologist by training, and I'm heading the gynae program at Vall d'Hebron Institute of Oncology in Barcelona, Spain. I'm very excited to share this night with all my colleagues.
Maddie.
Yeah, I'm Matt Powell. I'm a gynecologic oncologist at Siteman Cancer Center, Washington University in St. Louis, Missouri. I lead the division there, and I also for the NRG chair the Uterine Corpus Committee, and so excited for all these advancements in endometrial cancer, and obviously seeing this crowd tonight, you are as well. So thank you.
So what are we going to do today? Let's add to our knowledge of where we are. Share what we've gained here just in the last month or so with regards to the new data, and really talk about how that fits into the paradigm of endometrial cancer, and really look to equip or add to our skills in creating how this is going to impact our patients, and how we're going to work together to mitigate and manage adverse events, which will be really a reoccurring theme today. So I'm going to talk about really integrating that molecular testing and how we're going to do this, more of just a primer, okay? And as we look at this is some of the challenges that we're going to face as practitioners. And I really love sharing the stage for Anna in a European perspective. We'll talk about that. But let's first step and talk about uterine cancer. We continue to see increasing incidence of uterine cancer. We talk about ovarian cancer, how the incidence going down, but prevalence going longer because people are living longer. We're not seeing that in uterine cancer. We'll talk about that in a second. Postmenopausal is the average age of diagnosis at 63, and overall we do pretty well with 5-year disease-free survival. Obviously, the earlier we diagnose patients, the better their survival, and you see that on the bottom right. If we diagnose them in localized early stage, their 5-year survival is about 95%. Regional, meaning lymph node metastases, we still hit 70%. Imagine that. Metastatic disease to the lymph nodes where we still see a 70% 5-year survival. Unfortunately, don't do very well in our distant. This disease really calls out the disparities that we're seeing. And amazingly, when I started this field about 20-some years ago, ovarian cancer was a death sentence. And if someone's diagnosed, we said, we'll give you a couple of years and we'll do the best we can. Amazingly, on our current trajectories, the death rate from uterine cancer is approaching that of ovarian cancer. And it's disparately seen in our Black patients. And this is much of the work all of us on this stage are doing and throughout the country with our peers, trying to identify why our non-white patients are so adversely impacted. And I wish I had the answers. I don't. We're going to continue, I promise you, every day to work to answer those questions. So this is really a molecular disease. We used to lump everybody, Matt, remember us in the NRG meetings, and they're all lumpers. Everybody's the same. You have uterine cancer, that's so far from the truth. We talk about when we talk about the Cancer Genome Atlas research, it really differentiated and showed that we had 4 distinct molecular subtypes. I've updated this slide to really bring into the most common nomenclature. You hear us talk about poly or ultra mutated on the far left sides. Really mutated tumors which are recognized by the body's immune system. Then we have these dMMR, mismatch repair deficient or MSI high tumors. We use those terms interchangeably. You see here again the molecular signature. On the left there, we call those the hot tumors. Those are the ones that are going to respond best to immune therapy, but we see that we've made some great strides in those. On the right, you hear us say mutated low or low mutated tumors, but really usually what we refer to as NSMP, which is non-specific molecular profile, or microsatellite stable, okay, or MMR proficient, or P53 wild type. But we will mostly refer to those as microsatellite stable or non-SMP during this talk. And on the far right, those are bad behaviors. These are the P53 abnormal. Copy number high, we don't really use that term very much. We do on this slide, and we all have this slide, or somewhat close to this slide. But really the P53 mutated, and you see that schematically on the bottom. And why do we care about this? Look at the performance in the upper left of the TCGA in the performance of these different subgroups. On the right is PORTEC 2, which looked at vaginal cuff brachytherapy versus whole pelvic radiation in an intermediate risk factor early stage disease. PORTEC 3 on the bottom was actually looked at the recurrence-free survival on the left and overall survival on the right, looked at chemotherapy plus radiation versus radiation alone. Look how well the poly mutated. These tumors are recognized by the body's immune system and kept at bay. But very close are our NSMP or our dMMR. But as we look at these bad behaviors on the low red lines, on each one of those curves are P53 abnormal tumors. And you see the impact. Again, this is a slide where we've lumped in all the interventions, and we're going to talk about a little bit about how those impact. For those who treat beyond endometrial cancer, when we talk about Lynch syndrome, everybody thinks colorectal. When we're looking at MMR deficient and the incidence and deficiency, it's actually highest endometrial cancer. And you can argue in women, even in Lynch syndrome, they're diagnosed at a higher rate. And when we look at the breakdown of proficient versus deficient patients, about a quarter versus 3/4 that you see there. So about a quarter are dMMR, about 3/4 are proficient patients. Now, this was adopted by the NCCN, from the NCCN. And this is really what we are looking to diagnose the molecular subtype of these patients. So what's the first thing we should do? And Anna does this at her institution, but I don't. I'm going to come back to that. Polysequencing, trying to identify the hot spots on the tumor, which will identify those patients who are going to do the best. If we don't see a poly mutation, then we say, do they have MMR? If you have loss on IHC or MSI testing, then you have the deficient tumor. If your expression's retained, you then look at the P53 immunohistochemistry. And there is where we have those NSMP, nonspecific molecular profile, or those that are high. And clearly those that are abnormal, I don't mean high, excuse me, I misspoke. Those that are abnormal are the worst behaviors, and we see similar opportunities in those groups. So how do we test for MMR? Really it's IHC, and across most of our institutions, even if you're in the earliest stages, we get MMR proteins. Can you also do the MSI testing, looking at microsatellites? Yes, but most of us stick with the MMR, and maybe we should look at MSI testing to identify that small group of patients that aren't picked up on MMR. And how does this look when we're looking at predicting response to immune therapy, which we're obviously going to concentrate on with the 2 recent positive phase 3 trials? TMB and PD-L1 expression doesn't seem to predict very well in endometrial cancer, the responsiveness. TMB, we have an agnostic indication in TMB. Maybe we should check it. But obviously MS high, you see here with the overlapping diagrams, PD-L1, again, a non-predictor. MSI and TMB, most of those should be the same, though there may be a small group, 5%, that aren't picked up on the mismatch repair proficiency. And maybe for 5% opportunity in decision making about our treatment, that we should be testing this. And we have to look in the mirror about the opportunities here from a molecular standing. What are the other challenges? Well, the other challenges are, how do we do all of this? And the reason we're doing all of this is to identify those patients most apt to respond to immune therapy. I don't think I need to tell this audience the importance in how well immune therapy works, particularly in those deficient patients or MSI high. But we know that removing those blockade, allowing the body's own immune system to kill the cancer cells is much higher when we have a deficient patient. But it's not just all about MMR. We have other biomarkers are really seen to predict other treatment interventions. We have the development of antibody-drug conjugates versus HER2/neu. We have trastuzumab that's been studied, and I think, Matt, you're going to talk about that a little bit, with regards to the utilization in our patients in those p53 wild-type or serous cancers. And we see at least 25 to 30% of our serous cancers, and you could probably say p53 mutated tumors, that are going to have high expression or 2 to 3 plus expression. Now, this is all being redefined on how we redefine our testing. Typically, or historically, I shouldn't say typically, historically, we've tested HER2/neu in uterine cancer using the breast cancer criteria, excuse me. But we're finding out lower expression. So every patient I see that I have negative HER2/neu, I need to go back, because I write it right in my problem list, right at the assessment plan. I have to go back and say, what did I mean by negative? Was it 2 plus with negative FISH? Was it 1 plus? Because we know there may be an opportunity to participate in clinical trials, even if they're 1 plus with their IHC. But it's important for us to continue to look not just at the subtype in the next generation sequencing, but also some of the IHC tests that we can identify. I put this slide together after a conversation I had with Anna at our last discussion. And she'll tell you in a second about what she does. But in the US, there's great regional differentiation, really across the world, but it will talk about the US, great regional differentiation about how we're molecularly staging our uterine cancer. And that's about to change because the staging is about to change in uterine cancers. So I put this slide together to say, what's the minimum we need? Okay, and I actually sat down with my pathologist, because this is what we're going to start doing at OSU. And I left the last meeting, I was embarrassed. And I was embarrassed that we can't keep up with our European colleagues on our testing. And I said, what do we need to do here, Adrian, Dr. Suarez, my pathologist? And he said, okay. So we came up with a list of that we should be. This is opinion of the minimum aspect here, okay? All patients had MMR-IHC, without debate. At least P53 and ER in grade 2 or higher endometrioid. At least that in grade 2, and you could argue all patients, and we'll talk about that. P53 and ER is just what I was saying, in grade 1, particularly if they have deep invasion and or extensive lymphovascular space invasion. HER2/neu in all serous cancers, and I would argue P53 mutated. I probably should have added carcinosarcoma to there, and I'll talk about that in a second. POLE patients in patients with grade 2 or histological features suggestive of POLE mutations. I get my reports from my pathologist, and they say, I'm worried this patient has a POLE. I make sure I send it. And really what we should be doing is sending these results as soon as we get the biopsy, so that we have their molecular signature by the time we do the hysterectomy, ideally. So that's not under minimum, that's a new bullet. I should have spaced that a little bit differently. But what's optimal? All right, POLE, Plus or minus next generation sequencing, she'll talk a little bit what she does. ERP53, HER2 new, all tumors, MMR, that's without debate, right? That's the optimal. Okay, where could we maybe cut some corners? Maybe cut some corners here. Well, in a grade 1A, minimal invasion, no lymphovascular space, do I really need PIG53? Do I really need POLE? Do I really need ER? Probably not. Those patients are cured, right? Serous cancers, they're all P53 mutated. Very few of them are ER positive, and very few are POLE, okay? Carcinosarcoma, you can make the same argument. Clear cell. Interesting, because you have low grade and high grade. So do we need PIG53 and clear cell? Because a histologic diagnosis, it is a different tumor. I think we should pull clear cell completely out. Matt, can you take care of that energy?
Yeah, next week. Yeah.
Okay, take that completely out. Probably say the same about D-differentiation and I-differentiation. Those are different tumors. I don't know, but they're nasty. So I actually think that I should do all the testing I can on those because I need to identify potential biomarkers. So all of this, why are we talking about this? Because just this past month, actually now 2 months ago, the world changed. And now category 1 for IO therapy in the first line. We still have consideration trastuzumab, trade name for that's Herceptin, trastuzumab, in the upfront setting. We also have the continued utilization of our immune therapy in the recurrent setting, particularly Lem-Pem, dostarlimab, and Pembro, all of those, both in an agnostic indication or proficient. We'll talk more about that. Maddie, let's go through yours, then we'll do some cases. Does that sound like a plan?
Sounds perfect. It sounds perfect. And what a great introduction to this. I think really understanding the molecular aspects of this is key to putting all these trials and the subgroups into context. And we'll be talking about maximizing the benefit of immune checkpoint inhibitor regimens in the frontline setting. I actually get the easy part. I think Anna's going to have the tricky part, what to do later. And these are big things coming up, and that have data that we'll be sharing with you today, snapshots of our phase 3 immunotherapy trials. And it is just an amazing time. I think when the first 15 years of our practice, maybe one trial would be running in endometrial cancer, and it's such a difference. And I've had the opportunity to be participating in the top 2 studies with Ruby and GY018, and both of them are our standard cytotoxic backbone with carboplatin paclitaxel plus minus a immunotherapy agent plus a little sprinkling in of PARP inhibitors, and we'll be talking about that. Duo-E, you just heard Duo-O at ASCO here recently. Now, Duo-E is different. It's for endometrial cancer, but similar strategy, having durvalumab plus minus olaparib maintenance for patients with endometrial cancer. So Duo-E's had a press release, so we know there's a signal there. Attend is similar with different agents, as shown there with atezolizumab. We have Keynote C93, which is actually looking at getting rid of chemotherapy and just using the checkpoint inhibitor in our defective mismatch repair population. Dominica, the same, only with dostarlimab. Then we have another study that really could alter the landscape, and that's a non-chemo regimen with lenvatinib pembrolizumab versus chemotherapy with carboplatin paclitaxel. So figuring all this out, a year from now when we come to give this talk, we'll talk about how we can sequence all this, what we can learn. So what about combinations? What are we trying to do here? And we know single agent activity we have with checkpoint inhibitors. About 50% of the time the tumor will respond if it's defective mismatch repair. Only about 10% of the time if it's a proficient tumor with single agent checkpoint. How do we do better than that? So combination therapy, especially if you're going to add it to chemotherapy, again, killing the cell, hopefully is creating neoantigens, hopefully helping our immune system see the cancer, and better antigen presenting, probably an effect on the tumor microenvironment that's important. So we think this strategy of immunotherapy plus chemotherapy is a valid strategy, and we'll show you that it is, much in line with what we see in lung cancer and other things. So getting right to the meat of it. So it was, and Ruby was, both these trials are similar but different, and we can talk about some of those key differences. But again, this is patients' first-line therapy, essentially. They may have had prior therapy given adjuvantly and still go on the trial, so it may be the second time they've seen carboplatin paclitaxel. But these patients had recurrent, mostly measurable disease patients, and then they were stratified based on their MSI status, prior radiation, and or their disease status. They received dostarlimab at 500 milligrams IVQ 3 weeks, and they had 6 cycles of carboplatin paclitaxel, and then they received maintenance dostarlimab or placebo, as shown there in the Q6-week strategy. Primary endpoints, PFS and OS, and the secondary endpoints included BICR, which I just presented about an hour ago at the ASCO, and the overall response rate, DOR safety, and PROS. And I won't go through that on every study, but we'll talk a little bit about these things. And really, you can see it even from the back of the room. We don't even need a huge graph here to note that in that DMMR population, staggering differences. And also looking at the shape of that curve, this is progression-free survival with dostarlimab plus chemotherapy. And there's 2 parts of RUBY. That's why part 1 did not include the PARP inhibitor of niraparib. Part 2, we don't have those data yet, but the trial's accrued. But you see this hazard ratio of 0.28, just big differences in those curves. The evaluation also was the overall population, which includes those proficient patients, and you see the hazard ratio of 0.64 in this group. At 24 months, 61% of the patients were still without progression, and you see how flat that curve is. Those patients were starting to feel like they're cured. And we don't use that cure word for a few years yet, but it's really been quite staggering, the differences seen here. And then we have some overall benefit as well. Overall survival showed a difference here with this hazard ratio of 0.64 in the overall patient population. This is not yet mature, but had a p-value that was highly impressive, so we don't necessarily think there'll be a difference there. The 24-month OS in the DMMR group was 83 versus 58%. That hazard ratio was 0.3, so just really showing us the benefit. The 24-month OS in the PMMR group was 67% versus 55. Again, hazard ratio 0.73. If we had that sitting by itself, everyone would say, this is phenomenal. But when you put it next to the DMMR population, people are scratching their head, well, is that good enough? And I would say 0.73 is pretty impressive. And again, the overall population, that hazard ratio of 0.64. And when we look at some of the presentations that just happened in the last hour and a half, we presented the BICR analysis. So again, our registrative authorities, and they want to make sure we're telling the truth when we, as investigators, decide whether somebody's progressing or not. Really showed good concordance, and again, the hazard ratio stayed basically the same. Hazard ratio 0.29 and overall 0.66 in the progression-free survival. These benefits were seen consistently. When we look at the quality of life, again, this was a very well done prospective trial, good sensitive instruments for detecting quality of life. There was a diminution in the quality of life during the chemo period, but really, as we expect, as we put patients on chemotherapy, but really the patients tolerated this well, and no differences between the 2 arms. So the addition of the immunotherapy did not diminish quality of life, and in fact, may have improved it. Looking other frontline approaches, as I mentioned, there was a second trial also in the New England Journal on the same day, which was GY018, or run through our NCI mechanism, so through the NRG. And this was a very similar style trial, although powered differently. It was powered as really 2 separate cohorts of patients. The DMMR patients were separated from the PMMR patients and powered separately, leading to an 810-patient trial randomized to pembrolizumab versus placebo. They could get 6 to 10 cycles of carboplatin paclitaxel followed by maintenance pembrolizumab for a shorter period. And I didn't point that out as much. It was 3 years of maintenance with dostarlimab, and this is 14 cycles with pembrolizumab maintenance. And we'll be showing you these data as well. So again, 2 separate cohorts. The DMMR cohort showed that hazard ratio of 0.3. So again, striking differences between the 2 arms, and also maintained within the PMMR cohort hazard ratio of 0.54. Now, a lot of people make a lot of this, well, what's the differences between this trial? Why is the PMMR doing better, quote unquote, on this study versus the RUBY study? And we don't know yet. Is it better, or is it the 018 study was not very mature? This was reported probably the very day that it could be. It needs some maturity to see how these cohorts are going to do over time. But nonetheless, we see still very impressive results across the board here in both the deficient and the proficient tumors. What about the other studies? This, again, had a press release stating some positivity. We don't know the data yet, but positive high-level results were reported with clinically meaningful improvements in progression-free survival. Very similar, although this is a 3-arm trial, carboplatin paclitaxel with durvalumab versus the addition of olaparib. So 3-arm study investigating these 2 new interventions of immune checkpoint inhibitor and a PARP inhibitor with olaparib, and then the combination of those. And we do have some good preclinical data that this should be something important in endometrial cancer, and we're hoping it gets accepted to ESMO, and we'll see how that this data comes out. But the more interventions, and hopefully, especially in that pMMR population, which, as Dr. O'Malley mentioned, is the population that represents a lot of our patients with the worst disparity. Our Black patients tend to be in that proficient mismatch repair population. So what about safety? The safety profile in either the dostarlimab or the pembrolizumab trial was really consistent with what we see with the individual components. It was about 10% higher across the board when you add a checkpoint inhibitor to carboplatin paclitaxel. They're thankfully somewhat non-overlapping. Common AEs in both regimens, nausea, fatigue. Certainly we see thyroid problems, et cetera, as we do with other immune agents that are quite easy to manage. Similar frequencies of grade 3 and 4 AEs were identified in both the DMMR and pMMR cohorts in the pembrolizumab trial with the GY018. So other efforts, what else is going on out there? And this is a very nice summary of 3 trials, and the first 2 are trying to get rid of chemotherapy for our DMMR population. So Keynote C93 is an entire DMMR population, pembrolizumab alone versus chemotherapy with carboplatin paclitaxel. And then Dominica, very similar design with dostarlimab versus chemotherapy. And it will be some time. And when these results report, we'll have to say, well, what about chemo plus pembro? Is that actually better? And so there'll be plenty of room for another debate some night when we talk about how to interpret those trial results with the recent publications of 018 and Ruby. LEAP-001, as many of you know, also stands to replace chemotherapy in the frontline setting. Lenvatinib pembrolizumab, we know, and we're going to be hearing more about it, very active in 2nd and 3rd line in the proficient mismatch repair population. Lenvatinib's a multi-targeted tyrosine kinase inhibitor with VEGF being one of the main features there. Again, enrollment's complete on that study. I would think Q1 we'll see something on LEAP-001. So our immune-related adverse events, and I know as you talked about our introduction, adverse events are something that we all are concerned of. And any itis is certainly part of our checkpoint inhibitors. And dermatologic with rash and pruritus, which is fairly easily managed with our topical steroids and antihistamines. GI issues, these can be troubling, both obviously from the patient and the practitioner. How much should I worry about this in these patients? When do I institute steroids? And really that conversation with the patient, you got to tell me when you're having diarrhea because we need to be acting here. The endocrine disorders, mostly hypothyroidism, but it can be more extensive than that. Often we're, even as gynecologists, we're prescribing thyroid medications quite regularly now. So, and then our pneumonitis, which is our most scary of the side effects, hepatitis and pneumonitis. Certainly these patients need to be acted on quickly and work with hard-dose steroids. Now, ASCO's done a great job in providing us guidance in how to be managing these patients, and really with early intervention, we feel the safety profile here is certainly maintained. So what about the timing of these immune-related adverse events? And they really can occur anytime, but we have a bit of a sense from the compilation of data, and this was a publication from 2019, that skin rash tends to happen early, that colitis usually peaks around the 2nd cycle, and then later toxicities with the liver toxicity, and then endocrinopathies really can happen even remotely. Starting to see a little more nephritis. I think that is something that happens late in the game, as is shown here, and this peaked at 30 weeks of treatment, and something we certainly watch for and can manage usually fairly easily with the interventions. Obviously, communication with patients is critical, following up on our laboratory studies, what to watch for. And patient education materials are so crucial for us and our nursing team to help us manage these toxicities. What about HER2? And again, David mentioned HER2 targeting in endometrial cancer. And this was a passion project by Dr. Amanda Fader and group. Went out and did an investigator-initiated trial, randomized phase 2, looking at trastuzumab. We had previously looked at trastuzumab alone in endometrial cancer and saw no responses. But there was obviously a thought that combining it with chemotherapy could make a difference. This is the overall survival, showing a hazard ratio of 0.58 in the population. That, again, using breast criteria, were positive 2 to 3 plus, and then those intermediates were FISH positive. We've implemented another study to further confirm these randomized phase 2 data, and that's GYO26. It's an international study with trastuzumab or trastuzumab pertuzumab delivered in the sub-Q fashion for patients with HER2 positive endometrial, mostly serous cancer, carcinosarcoma, but anything P53 abnormal can go on this trial. This trial is just starting to accrue at this point, and many people ask, well, what does Ruby and 018 do to this? And we're investigating those HER2 positive patients on those studies to see whether they should be pulled out and targeted with HER2 agents.
So let's go to the patient case here. So Laura, accountant, postmenopausal by about 5 years, enjoys reading and traveling, came in with postmenopausal bleeding, very typical, very typical. Her biopsy shows a grade 3 endometrioid cancer. Because she's a grade 3, we got a CAT scan before. We don't do that for all our cancers, but our higher risk ones. And she had some enlarged lymph nodes. She has some comorbidities, very commonly we see with our endometrial cancer patients. And she underwent a TLH, stands for total laparoscopic HIST, removal of tubes and ovaries, BSO, and they're able to remove all visible disease, but she's found to have a metastatic implant in her peritoneum. So, and I want to hear from you, not just on this patient, but in general. Tell me what you're doing. And we're getting questions come in. Should we be doing next generation? Should we just do a hotspot POLE? Tell me what you're doing and tell me what you think ultimately we should be doing on molecular testing.
Absolutely, David. Thank you for the question. So let me tell you something. 1 year ago, we published the ESMO guideline, how patients with endometrial cancer should be diagnosed in terms of pathology or molecular classification. At that stage, most of the physicians don't perform any kind of molecular test. Now, what can I say? Due to the dissemination, the education that we have carrying out, most of the physicians order to their pathology the following: mandatory, there's no doubt, mismatch repair status. Mismatch repair status followed by P53 ER/PR status. Ideally, in academic center, starting with POLE. So what we do in MAPSI is POLE, next generation sequencing, immunohistochemistry for mismatch repair status, P53, and hormonal receptor status.
Mary, Matt, is that what you guys are doing?
I think, honestly, your slide really summed up what we've been doing now for a few years. When we started mismatch repair testing over 20 years ago. That was screening for Lynch syndrome. We didn't have any other predictive biomarkers, but we tried to identify those small percentage of families that had Lynch syndrome. So we were very apt at screening with IHC early on. And I think even when we were fellows 20 years ago, we knew P53 was bad. We just didn't know what to do with it. Yeah. So yes, we've really implemented that, and definitely would think this patient on her endometrial biopsy, I would send that off for testing. It may not change anything. She's stage 4B, but at least gives us markers, allows us to start thinking about clinical trials and driving this as a molecularly based care for this patient.
Yeah, if she's POLE, I'm not there to say, oh, she's POLE and she's stage 4, I'm going to omit therapy for her, de-escalate, right? So in an early stage disease, that could impact, but not in this particular patient.
Absolutely. Let me tell you something, if I may. So I think now in endometrial are almost at the same level in terms of ovarian cancer and molecular characterization. So I don't think now we can say, patient, you have an endometrial cancer. what is this? It's as I called you, you are David. David, what else? So, I mean, we need to start explaining our patient that they have an endometrial cancer with these following molecular features. And according to these molecular features, you will be candidate to one therapy or to other.
Well, that's a great point. We need to change the way we talk about them. And that's why I changed that slide, and we need to be more consistent in our messaging. So Matt, this comes to a question that came in. Are you checking copy number? Outside of academic approaches, what does that mean? Are you checking that, and should we even really be talking about copy number low, high?
No, we don't. I mean, you can, and the MSK Impact does give them copy numbers, so there are institutions that do it. But for the most part, we can use P53 as the surrogate. So P53 aberrant tumors really put you into the copy number high group, and that group that doesn't test positive for mismatch repair or P53, they fall into that NSMP group. So it's really not necessary to figure out copy number, but that is rather academic.
Yeah. So Anna, we had a question come in, and really getting to a question about this discrepancy in care in the United States. And they said in Spain, you should have equal access with more of a socialized type of a healthcare system. Do you see differences in nationalities, in races, in Spain when you have access to healthcare, or is this a problem just for the US?
I mean, thank you for the question, but it's quite difficult to identify in Spain this kind of disparity. I could say that 80% of the population have access to the health system regardless of origin, regardless of ethnicity, and regardless of social status. So, I mean, all patients have access to all these kind of the molecular tests and all the therapy that we consider that is the best for that. So now I could say that due to the, more diversity in the population that we are having in our country, we are collecting if we will be able to identify some disparity, but I cannot say right now that we see these differences.
So Matt, is it the determinants of health? Is it access? Is it molecular? Is it all the above? I mean, I know you've done a lot of work from the molecular standpoint. Tell us with regards to some the differences we see in our outcomes. Easy for me to say.
And clearly, it's a component of all the above. Delay in diagnosis, certainly. Access to care, certainly. How much those are a component is really interesting. When we look at our military population, which again, all have health care, maybe they're not getting equal access in the healthcare, but at least they have it and it's available. There's still a worse outcome for endometrial cancer among black patients. And similarly, on clinical trials, we just did this large trial looking at metformin, GOG286B. The black patients getting the exact same therapies did half as well. I mean, it's staggering, and we do have a large grant through the NCI, which one of your partners, Casey Cosgrove, is leading, looking at these molecular characteristics that are really leading to these disparate outcomes. And within that trial, we have mounds of demographic data and exposure data, zip code, all these things that we can see. Is it something environmental? What's going on for this big disparity to still exist?
And what's some of the best ways to overcome some of our implicit bias? Clinical trials. We know that we have access from a standpoint of getting access to clinical trials is difficult, but all patients being offered and encouraged to participate in clinical trials, so important. So Laura still enjoys reading. Let's go down there. IHC revealed deficient DMMR, okay, loss of expression of MLH1 and PMS2. She's feeling a little overwhelmed. She's worried about continuing work. She's worried about potential side effects. Matt, what are you going to do? What are you going to talk to her about?
Well, I think she needs to know. I mean, you showed that data, stage 4B, less than 10% are alive in 5 years. What we used to do. I think we need to say, there's new hope for her. It allows her to continue to travel and do the things she likes to do, but it will require therapy. So I think that we need to think about and really talk to her carefully about moving ahead with therapy. It is quite striking. Some patients, it takes some time to let this set in, to really understand the impact. A lot of patients come in and say, there's no way I would ever take chemotherapy, and really it takes a lot of patient education sometimes, and we take that for granted.
Yeah. And what would you offer? What would you tell her she needed in this scenario?
I mean,
yeah, go ahead. Yes.
I'm sorry. So I think it's very important to explain this particular patient what they can get if they receive only chemotherapy. What is the median PFS and the median overall survival that she can expect for the, the current standard first line based on paclitaxel carboplatin. And when you explain, when you add IO to chemotherapy, the risk of recurrence is reduced in at least 70%, 70. I mean, they must understand, that there's no option just to get this gate of benefit. And there's another point, so when you see at the patient, you need to receive therapy for 3 years, you need to receive therapy for 2 years, according to the Ruby or the 018, you need to explain that after chemo, they will receive the therapy every 6 weeks. There's no reason to cancel any travel, any family visit. They can manage the schedule with 1 every 6 weeks, 1.5 months is nothing.
Yeah. Well, but we do have some challenges. So with regards to Laura, we recommend carboplatin and paclitaxel. We're not going to get into the shortages quite yet. If we have some time, we'll get into that in the U.S. For our European colleagues. We're facing really maybe disastrous shortages of carboplatin and cisplatin. But so we recommend carbotaxel plus IO, dostarlimab versus pembrolizumab. Okay, one of them, without debate. And Matt, you mentioned this, and I wanted one of our colleagues on the stage to talk about curative intent. It is time for us to start to talk about the chance that we're going to cure you with your stage 4B disease, which I never would have talked about in the past. What is the difference between the outcomes and beyond those 3 years? It's really at 2 years they start to flatten.
Yes.
In those 2 trials, yes, a little uncomfortable saying cure, right?
Yeah,
what's the reality?
But we see it in our practice. Now these patients are out 3, and again, some of those that are on the single agent trials with effective mismatch repair, they're out 4 or 5 years. Do I stop my checkpoint inhibitor because they're holding on to it like I have no side effects, I'm doing great, and I look like I'm cured? When we talk about that, when to stop. And the nice thing about these upfront trials, they actually had an endpoint. A lot of our earlier trials didn't. And so, we usually think about a year or 2 after complete response. But yes, we're using that cure word a lot in the clinic.
And I think we need to look at the chance less than 10% cure with just great chemotherapy, maybe as much as 30, 40%. That's what the numbers we're looking at. So, all right, a little harder. What do you think? She's PMMR. Who wants to start? Who's going to take it?
Go ahead.
All right, I want to hear. She's PMR. She's not DMMR. That's drop the mic. Right? Everybody gets a PD-L1 inhibitor, okay? Now she's PMMR.
She's PMMR, and there's no doubt when you look at the Ruby trial and you look at the 018, that the benefit that the patients get is less than DMMR. No one is going to discuss this, but at the end of the day, when you add IO, it's superior to a standard of care, paclitaxel carboplatin. Why not are you going to offer a better therapy for our patients? So a few years ago, we have nothing, just paclitaxel carboplatin. Now we have a therapeutic approach that is able to raise the bar. Why not? It's true that we would like to have more granularity in the PMMR. It's true that we wanted to wait at the mature overall survival. Yeah, but in the way, in the meanwhile, we can miss a lot of patients. We can lose patients. So I will offer for sure.
Absolutely. All right, Maddie.
And again, I agree. I think...
you don't get off that easy. No. Wait a second. So I check a HER2 new status. And she's P53 mutated. I think I'm just adding this. I'm making it up as I go. All right? Proficient. Okay? How do you have that conversation? What data? We have GY18 shows. Again, we're not that excited about hazard ratios of 0.5. I mean, this is crazy. I mean, this would have been, the PMMR would have been dropped to Mike not that long ago, right? So,
Exactly. Yeah, I think, so she's HER2 positive, P53 mutated, is that what you're telling me?
and she's proficient.
And proficient population. So, you know, I have a trial for her if she's interested. GY 026.
The easiest way,
nice.
way to respond.
But that's a tough one. I mean, I think the way I would say, you know, if off trial, presenting things head to head, I would probably favor checkpoint. And the reason for that is the ADCs that we have in our back pocket now that for HER2 are showing phenomenal responses. And it may be better than what we have with trastuzumab and pertuzumab. I don't know that yet. This is a delicate discussion when you think about trastuzumab for the HER2 positive patient. And again, she would not have been eligible for the other trial because she wasn't serous. So it's still a little bit of this unknown. Yeah. Now, we could probably get her on the new trial, but I think ADCs have come a long ways, and it may be better than just thinking about trastuzumab by itself.
And we are going a new world with ADCs on this particular patient. So I'm pulling out Monica Levine, my senior fellow. We're pulling out the curves. It's completely invalid. But here's me with my computer, my Mac, and line up the curves from the trastuzumab and GY18. I honestly can say I don't know what I would. Yeah, I have this conversation, and I also would favor IO in this circumstance because you have two definitive phase 3 trials versus a smaller, non-blinded, no bicker phase 2.
Plus, if you look in that serous group in 018, the forest plot, that 95% confidence interval is all on the side favoring checkpoint. Again, we didn't show that to you, but I think there's enough reason to say checkpoint now.
And again, I'm asking these questions to have a dialogue, you know, we truly don't have the answers to some of this. This is not just for we're not just up here from an entertainment standpoint. These are the questions with the patients.
You're very entertaining.
Thank you, I appreciate that. But when a patient's sitting in front of you and she is saying, Doc, what are you recommending? Somebody asked a question, should we refer all patients with uterine cancer to large academic referral centers before initiating therapy? I don't believe you need to send all your patients to the larger centers. But I think there are patients like this one, a stage 4, getting them access to clinical trials, getting access to these very difficult discussions, which we don't know the answers to, and this is what we do every day. This patient should be seen at a large referral center, at least in consult, and then partnering with our community medical oncologists for these treatments, but very, very important. So high-grade tumors, carcinosarcoma, P53 mutated, making sure the molecular testing is done. Maybe if it's not being done in those community, having a consult at the larger center with regards to molecular testing and having those discussions. Very, very important. All right, Anna, what do we got?
Okay, now, I'm feel that I have, the poorer part because, we have showed this marvelous data in first line, so I'm moving to the recurrence. So what do we know? We know that, until now, I would say, still in Europe, the standard of care is paclitaxel carboplatin. In Europe, in another part of the world, although we would like to treat our patient with IO, we cannot. It's not still approved, it's on the way. So, standard of care, paclitaxel carboplatin. What happened with this patient? Happened that when this patient progressed, when they fail to platinum therapy, they are not a standard of care, or there was not a standard of care. I think we should speak in past right now. So then in this scenario, immunotherapy emerged as a really game changer. David has already explained very well the implication of molecular classification. How can we split the patient in those whose tumor harbor a mismatch repair deficiency and in those who are mismatch repair deficiency? We also know that there are several checkpoints in development, but today, the only 2 checkpoint inhibitors that have been approved for the treatment of recurrent of advanced endometrial cancer after failure to platinum is pembrolizumab and dostarlimab. Why we have these new drugs approved in the endometrial cancer field? Let's start with pembrolizumab. As you know, following the initial efficacy signal that we saw in phase 1. The Keynote 158 trial was developed. It was a multi-cohort clinical trial, and in the specific cohort for endometrial cancer, we enroll patients with endometrial cancer DMMR of MSI high. All patients must have received previous line of therapy based on platinum, and all patients must have measurable disease. Why? Because the primary endpoint was overall response rate. So we must determine the tumor size shrink when we treat this patient with pembrolizumab. Another important point, all patients receive a flat dose of pembrolizumab, 200 milligrams every 3 weeks IV. And then what about the duration of therapy? The duration of therapy was up to 35 cycles of progression of prohibited toxicity, whichever occurred first. So we have learned from 158, we have learned that pembrolizumab provides a really compelling anti-tumor activity with an overall response rate of 50%. 60% complete response and 34% partial response. And I always say the same, it's not only the overall response rate, but the duration of response. When you look at the median duration of response for those patients who respond 63 months, it means around 5 years, This is really amazing for patients who have progressed after platinum therapy. So this trial led to approval of the pembrolizumab, although they have diagnostic approval as well. What about dostarlimab? I mean, the development of dostarlimab started in the Garnet trial. Garnet trial was born as a phase 1 trial to determine the recommended phase 2 doses. When we established this phase 2 dose, then we have different multiple cohorts where we wanted to see the really activity of dostarlimab. One of these cohorts was called A1, and then we enrolled there patients with the MMR MSI high. What you need to know is that the status of mismatch repair was locally determined, and then we enrolled patients who have received up to 2 lines of therapy. And it's something that I would like to stress. We could enroll patients who have received paclitaxel carboplatin as adjuvant therapy for stage 3C2. So patient received the schedule of dostarlimab, that it was 500 milligrams every 3 weeks for the first 4 cycles, and later on, 1,000 milligrams every 6 weeks. I mean, this is a really convenient schedule, and I can say, the dostarlimab was the first anti-PD-1 that started with this schedule. So what we learned from the Garnet trial and dostarlimab? Okay, so firstly, I would like to point out that the Garnet trial, the cohort A1, is the largest series treating DMMR endometrial cancer with single-agent anti-PD-1 therapy. 143 patients. We show a really compelling overall response rate, 45%, 16% complete response, 29% partial response. And once again, I go back to the duration of response. The median follow-up for the Garnet trial is 27 months. As you can see here, 83% of the patients who respond, they are still in response at the time of cutoff. So then what happened? I mean, we have shown, we're very proud of this data, David O'Malley, Keynote 158, or Garnet trial, but we are talking about the best population, DMMR. So we haven't seen the data from the PMMR. What happened with PMMR and single agent IO? That the response are really poor, they are not really compelling. So we need to find some way to improve the monotherapy activity. As Matt showed, chemotherapy and IO has a synergistic effect. And then we learned from the Keynote 146, when we add an anti-angiogenic to IO, we can obtain this synergistic effect, and then we increase the activity of IO monotherapy. This was the first signal of activity, phase 2 trial, and then according as a result of this phase 2, the phase 3 trial was launched. The phase 3 trial is Keynote 775. In this trial, we enroll patients with advanced metastatic recurrent endometrial cancer Patient may have received paclitaxel carboplatin as adjuvant therapy, but they have relapsed less than 12 months, and all patients must have received measurable disease. Important, there's a stratification factor, mismatch repair status, DMMR or pMMR, and among pMMR we had an additional stratification factor, region, ECOG, and history of radiation therapy. And then the patients were randomized in a one-to-one fashion to a standard of care, chemotherapy, either doxorubicin or weekly paclitaxel, and experimental arm, lenvatinib, lenva, 20 milligrams of pembrolizumab, flat dose, 200 milligrams. Primary endpoint, co-primary endpoint, PFS by BCAR and overall survival, and secondary endpoint, overall response rate. So, the trial was positive. The trial met its primary endpoint. The combination of pembro-lenva increased, prolonged the median PFS in the pMMR and in all-comer population. And this is the final analysis. The first analysis were published in the New England Journal of Medicine, and recently this data has been published with an additional 16 months of follow-up. And you can see the hazard ratio was 0.6 for the pMMR population and 0.56 for all comer. The median PFS was 6.7 months for the lenva-pembro compared to 3.8 in the pMMR population. What about the overall survival? The trial was also positive according to this primary endpoint. Pembro-lenva significantly and clinically significant prolonged the overall survival for our patients. In the pMMR, the lenva-pembro median overall survival 18 months, 12 months, 1 year for chemotherapy. And in all comers, exactly the same. The hazard ratio for overall survival was 0.65, median overall survival 18 months for the lenva-pembro and 12 months for chemotherapy. So there's no doubt that the combination is superior to chemotherapy. What about the overall response rate? Remember that this is a secondary endpoint. When you look at the lenva-pembro in the pMMR, the overall response rate was 32%, just 50% in chemotherapy. In all comers, 33% for the combination, 50% for chemotherapy. And then I'm sure that you are asking yourself, what about the DMMR population? The first thing that you need to take into account that this is an exploratory analysis. In the 775, the population DMMR was capped per protocol, so just is only a low percentage of the population. Nevertheless, lenva-pembro was superior in terms of PFS and overall survival. And when we look at the overall response, interestingly, the overall response was 40%. Exactly, I will not say exactly because this is a cross-trial comparison, but it's very similar what we have seen with pembrolizumab monotherapy or dostarlimab monotherapy. So, then what about safety? So Matt has explained very well, the safety profile for IO. But when we come with the combination, then we are having two different agents, lenva with its specific profile and pembro with a specific profile. So let me tell you something, at the beginning of the use of this combination, people were very concerned about the safety. They didn't know really how to manage the side effect. Now we can say that while, using pembro-lenva, all the physicians, all the nurses, and most important, all the patients are aware of this adverse event. And when you are aware of adverse event, you can identify early. If you identify early, you can establish the best therapy for this patient. So, for example, one of the most common adverse events for the combination is diarrhea or colitis. What is the first recommendation? Stop lenva. Why? Because the half-life is short, and then we'll see what happens. Unfortunately, after stopping lenva, the patient still suffers from pembrolizumab. Then you need to start the side effect as immunomediated side effect. But the bottom line, the take-home message is learn how to manage the side effect and identify early. So for that, all healthcare provider and the patient must be aware of the kind of side effect that they may suffer. And finally, last but not least, we have shown that we have several options of therapy for our patient after platinum therapy. So we must integrate patients' knowledge and patients' decision on the best therapy for them. Patient must feel confident on the therapy that they are going to receive. This is the reason why we should explain the therapy, we should explain the benefit that they may get for a particular therapy, and then all together, make the decision on a particular patient's therapy. That's all.
Fantastic.
Well, yeah, it's wonderful. And I really, when we look at this from a toxicity management, we really have become really good friends with our dermatologist and our GI, our rheumatologist. I never thought I'd be reviewing so much rheumatology. So let's talk about Maria. Retired as being a librarian a few years ago, continues to be an avid hiker, very active with young grandchildren. She undergoes minimally invasive hysterectomy, BSO, sentinel lymph node dissection, finds a grade 2 endometrioid uterine cancer, stage 3C1, so positive pelvic lymph nodes, that regional patient we were talking about earlier that we're doing much better than we used to. She's also proficient. So she was treated before, did not go in clinical trial, was treated before the most recent data, got carbotaxel, did well, then unfortunately at 7 months shows up with GI symptoms. CAT scan shows us suspicion of recurrence. We confirm it with a biopsy, okay? So kind of jump to, what would you do on this patient? But from your data, with what we've talked about, pretty straightforward, the proficient patient, LenPem, right? All right. So now she presents with grade 2 diarrhea. So go over that a little bit. Okay, so she calls you, she calls the APP, she calls the nurse, and and they say I'm having diarrhea. Early on, the nurse in my practice would say, "Oh, that's not us. Call your primary care."
Exactly. That's
right?
the point. That's the point.
So tell us about how did you educate your nursing team with regards to the importance of this, and then how would you then go into a little bit, how would you manage her? Say she's at between cycle 2 and 3.
Yeah, this is a very good point. So I remember when we were starting to run the 775, we were not really aware about the side effect. And then, these patients suffer from diarrhea grade 2. They call to the emergency room, okay, toma antidiarrhea, drink some liquid, that will be enough. And then this grade 2 became a grade 3. Yeah. Now we know when the patient under this kind of therapy called to the emergency room, called the clinical nurses, the first step is stop LEMBA. Stop LEMBA, drink a lot of liquid and see what happens in 48 hours. If the patient continues with diarrhea despite stopping LEMBA, then we start with GI consultation, colonoscopy, and biopsy to determine if there's just a grade 2 diarrhea led by LEMBA or the patient is suffering from immuno-related diarrhea. But I think the key point is, as I mentioned before, identify early, not neglecting identification of immuno-related adverse event.
So Matt, she gets admitted on a Friday, right? She gets admitted on a Friday. She's starting to get sick on you. She's starting to have some vital signs staining. She doesn't look good. You can't get a colonoscopy. What do you do with that patient?
So certainly a stool assessment's a good idea. Obviously there's some specific things we can look at, but that patient's probably getting a scan, making sure not something else going on, bowel blockage or other things, but pretty quick to institute steroids. I think there's really little downside, even if you can't get that confirmatory scope of starting steroids for these patients, because they can get, as Anna just mentioned, sick really fast. And obviously there's good guidelines within ASCO and other agencies that help us manage this toxicity, but it's certainly not something that should be ignored.
So get the C. diff, make sure she doesn't have C. diff, and then get started on steroids. I think we once we give that 24 hours, but if they're not getting better, even if they continue to get worse in that first 24 hours. And really, when we look at this, the multidisciplinary approach in teaching our colleagues across the country, we don't have to do this alone. Find some people who you trust in GI, derm, pulmonary, endocrine. And again, I can't believe how much new Synthroid I write for now, right? But blood pressures, referring them to their primary care for blood pressure, hypertension of lenvatinib is not going to fly. It doesn't get managed. It can get scary. So really, when we look at this, we put this slide up because those are the most common toxicities, and they're most common overlapping because we see the dermatologic with the lenvatinib. We also see the dermatologic, obviously, with our IO therapy. It's the most common by number-wise that we see with IO. Many of those are early grade, and we're able to manage them with local therapy and don't have to go to systemic steroids. So making sure we have a multidisciplinary approach and that we're going forward. I really want to take this opportunity to talk a little bit about the previous case before we start talking about clinical trials, and you're not. So this particular patient received lenvatinib pembro, right? But we're going to, should we, in that patient who's proficient, what should we be doing in the patient with prior? I'm going to have Matt start this time. So this patient, let's change a little bit. She was treated on trial, okay? She was treated with an IO, single agent. And she's progressed, instead of 4 months, 7 months, she's progressed 13 months. What are you going to do with that patient?
Yeah, so the 13-month progression patients, are create an opportunity where you start to think about, should I reintroduce carboplatin paclitaxel? And here we didn't mention it before, but one of the reasons we also check P53, and it may be an opportunity for us to add in bevacizumab. We have good evidence from one of our randomized phase 2 trials, GOG86P, that those P53 mutated patients are ones that specifically benefit from the addition of bevacizumab. So I might think about a carboplatin paclitaxel bevacizumab regimen in somebody that's prior exposed with IO therapy. I'm going to consider lenvatinib pembrolizumab for the same reasons, though. And I know it's IO after IO, but you have this time period, you're saying 7 months after they completed their therapy. So certainly something to consider going with len-pem, even though they were prior IO exposed. We just don't have much data yet.
Well, we need that data, right? We need that data with the IO exposed in the lenvatinib pembro arm. So Matt doesn't have much data. He's talking to the patient. Gets treated len-pem, progresses after 4 to 6 months. I'm getting a question here. What's your next line? What's your next line? I mean, what's your third line after IO? Maybe it's really second line if you're not going to go with len-pem. I mean, what's our options in endometrial cancer right now?
For me, the easier way will be to put the patient on an ADC clinical trial.
Yes.
Right there.
There's no doubt, ADC clinical trial is the future after IO.
When we go back to control arms in the lenvatinib pembrolizumab trial, we have Taxol, we have doxorubicin. Not favorite drugs, but they still have a role to think about retreatment of these single agents. So.
And how about Brian Slomovitz's favorite?
Yeah.
Probably not in this particular patient, but again, she is ER positive. Hormonal therapy, right? Hormonal therapy.
Clinical trial with hormonal therapy and cyclin inhibitors.
But also, that's when the next generation sequencing is making potentially such a difference because we're identifying targets which may be actionable for clinical trials and even sometimes off clinical trials in a patient who you don't have a clinical trial for. Now, what are you doing, Matt? I think we have to talk about this, and the reason I'm going to Matt is because it's US-based. I mean, why can't we get carboplatin, cisplatin? Don't ask me why. Don't answer why. I asked.
What are we doing when we can't get it?
When we can't, this is a real problem. This is a real problem. Methotrexate, carboplatin in the US, not in Europe, because of the way our system's set up. I mean, how are you counseling your referring physicians? How are you doing it at your own center?
Yeah, so we just finished up the endometrial guidelines, and I know our SGO, GOG partner, or GOG Foundation came out with a statement for cervical cancer and ovarian cancer about alternate therapies. and that is, will be coming out soon for endometrial cancer. The use of oxaliplatin, I think, is reasonable. We have very limited data in endometrial cancer about replacing our platinum with oxaliplatin, but I think that may be a short-term strategy. We're, obviously working with the NCCN to allow those things to happen. It's a real problem, and I actually have my first oxaliplatin taxane pembrolizumab patient starting. She came from another institution. We have enough to finish some active therapy. So new starts right now, we're going to a non-carboplatin cisplatin and using the oxaliplatin, which again has its own issues with the neurotoxicity when we add in the taxane.
And while I torture these guys with some more questions, if anybody else has a question in the audience, raise your hand. We have some mics we're circulating. If there's anything we didn't address. So lenvatinib, you started on lenvatinib pembro. I don't know which case that is, but lenvatinib pembro back there. I just keep making them up, right? Lenvatinib pembro, horrible hypertension. She gets pressed.
Yeah.
You have to stop the lenvatinib in a proficient patient. Stop lenvatinib because of severe toxicity. Are you continuing the pembro? Are you continuing the IO therapy after you've stopped lenvatinib?
I mean, this is a very good point. So I guess, because I didn't face this case in my daily practice, we have been able to manage the hypertension. I think we should continue pembro with a closely follow-up. I will perform CT scan every 6 weeks, and finally, eventually we identify a progression, then we will modify the therapy. But according to the protocol, you can stop lenva and continue pembro, and it's what we are doing in the daily practice.
That's what we do too, Matt.
That's similar, yeah, exactly. There's a lot of patients too that the fatigue gets caught up with them. They need drug holidays, breaks, and using this dual compound therapy. There's an art to it, right? It's not necessarily what was done in the protocol, especially as you get out more than a year. A lot of these patients need breaks. They need time off therapy. Usually continuing the checkpoint inhibitor and giving a break from the lenvatinib works quite well for these patients. Then they go back on and treat. I have a lot of patients that they want to go down. They get all the way down to 4 milligrams for a bit, and the disease starts to come back. Then they go back on their 12 or 14 for a while and cycle it. And it's amazing. You see that disease control happen for quite some time.
So my lowest dose of lenvatinib right now is 4 milligrams every other day. And she continues to have disease stabilization, actually has a CR with her pelvic tumor. So, all right, Matt, I love your answer to this. What are you starting your dose on lenvatinib pembro?
I follow what you taught me. Yeah. I still write for 18 to give them the dosing strategies to 10s and 2/4s, but I certainly talk to them about the trial being 20, and I think that dose intensity may matter. It is hard to talk to patients about escalating when you start at something lower. Very few people are willing to escalate just from the fatigue factor, but we try. It's if you look across our patient populations, most of them end up on 14. So I think it's.
I would like to add the same. I strongly recommend starting at the full dose. What we should do is follow closely the patient. If the patient, develop prohibitive toxicity, then we manage. But we have data from the phase 2 that it seems that the patient who responds, 68% of the patients who respond, they have received the full dose of lenva. So, and it seems, that the receptors are fully covered when you start the highest dose. The recommended dose. So, start with the higher dose and follow the patient closely to identify any side effect that preclude from continuing with the highest dose.
And my academic, I agree 100%. From the pragmatic aspect, when we start at 18, they have 10s and 2/4s, so it's so much easier dose reduce rather than having the weight go down. Because what happens if they have the 20s, they have the 2 10s, so while you're waiting for the new 14 prescription, they end up getting 10 for that period. So that my reasons for starting at 18 is strictly pragmatic. I'm going to torture these guys with questions for the next 9 minutes unless somebody in the audience asks a question.
Please raise your hand.
I would say one of the things that you mentioned while the microphone's coming over is about hormonal therapy. How do we include hormonal therapy into our queue? And again, those ER-positive patients, really should be on our problem list, thinking about, do I think about everolimus letrozole? Do I think about getting them on a trial with a CD4/6 inhibitor? There's a lot of interest in that space, in that hormonal space.
Absolutely. Question.
Yes, I have a question for Dr. Agning. There's been a lot of debate about hypermethylation of MLH1, with Keynote 158 showing a detrimental effect, and the Garnet showing the contrary. Can you expand on that, please?
Yeah, thank you, Gonzalo. This is a very good point. So, firstly, I think we haven't discussed in this forum. So, all patients who are identified by immunohistochemistry with the DMMR, I mean, with the loss of MLH1, MLH2, or PMS2, one of the 4 proteins, I mean, should have a hypermethylation status by PCR by the pathology. So, if we identify hypermethylation status, we can say that this is not associated with a Lynch syndrome or like Lynch syndrome. So we have learned, I mean, if there's no hypermethylation, sorry, I will finish, then the patient should have a mutation analysis. I mean, the patient should be referred to the genetic counseling. So what have learned so far? I mean, the pembrolizumab data, I mean, they are 2 small phase 2 trials, and they show that those patients who have a hypermethylation in MLH1, they respond worse, and the PFS and overall survival are shorter for those. When we look at the Garnet trial, post-hoc exploratory analysis, it doesn't seem that it happened. It seems that all patients, regardless of hypermethylation status, respond in the same way. But I would like to say that this is all hypothesis generated. Now Matt will explain much better in the Ruby trial in the 018. I mean, they are going to analyze really this status and determine if there's an impact on the outcome if the patient has a mutation in the mismatch repair protein or they have a hypermethylation status. That being said, we are generating more data. There's a very interesting paper from the Memorial Sloan Kettering with a large number of patients treated, and once again, I see that there's differences in terms of prognosis and in terms of response to pembrolizumab if the patients, I mean the tumor have mutations in the mismatch repair that led to the DMMR or the patient had hypermethylation. The bottom line, all patients must be studied in terms of hypermethylation status or mutation status in the mismatch repair pathway. Thank you, Gonzalo.
Yeah. And making sure we get into genetics for those who are not hypermutated, right? I mean, I think that's a really important point to identify, and it's only going to be about 10% of those patients. So, you know, we clearly see benefit in those deficient patients. There may be maximum, maybe those numbers who, that cure word I used, may be that patient population you're referring to, but I think we continue to see benefit across all our deficient patients. Question here.
Yeah, I have 3 questions.
All right.
Yeah, there we go.
The first,
One
Have
for
you been to
each.
the bar? Yeah.
I'm going to get my pen out.
What would you? The first question related with the synchronous ovarian and endometrial cancer. Do you think that we need to change the way in which we analyze these cases because this evidence? The second one is related how we can detect the cold tumors at the beginning of the treatment to avoid using this combined therapy in those cases that are destined to not respond. And the third one, maybe it's for Dr. O'Malley, what about radiotherapy? Because in your slide never appeared the radiotherapy. You put the surgery and then the chemo. But if you are aware of radiotherapies, I say there is
What type of therapy is it?
Radiotherapy.
Radiotherapy.
Radiation.
Radiotherapy,
Oh, gosh.
radiation.
You put out.
Do we still do radiation therapy?
That's my point.
Start with the radiation therapy issue.
You know, that's a great question, and we really. So let me start with the third, and I'm going to turn it over to the harder ones for you, right?
I don't remember
So radiation
now.
therapy, we didn't really talk about local disease, and that really is. We just didn't have time, and we only have a couple minutes left. So we actually have the Rainbow trial. It's in Europe, and we're really looking at identifying those patients who are going to benefit from local therapy. But clearly, with the most recent data, we don't see survival advantage with the addition of radiation in regional disease. Now, I think there are some subsets, and we see in PORTEC 3, there may be subsets that are high-risk population that clearly could help people control disease. But from survival, we're not seeing impact, but there's definitely disease control. So I think there's some patients in the regional that could be still debated, but clearly with 258, we're not seeing that. But in the local control of disease, there still is an opportunity there, particularly in recurrence, which we know we do a good job of controlling disease. So the other question you had.
Let me just add to that.
Please.
So for GOG 258, we're looking at the molecular subtypes in that, and hopefully that'll shed some light on who should be receiving radiation. And then secondly, for GOG 249, which was our brachytherapy plus chemo versus pelvic radiation, similar things there. Hopefully within the next year we'll have that. I know it's taken a long time to get the funding to do that, but to really answer the local therapy question, where does radiation fit?
And so let's segue in. I think the first question was the synchronous ovarian uterine. Yeah, and there's some Matt, you want to take that?
And
then
so
and
actually
I'm
you'll see on the new FIGO staging that those patients do quite well when they're well staged, low grade. There's certain features there, and they're actually going to be moving them to a stage 2 because of that better outcomes for the synchronous primary population. And whether that's endometriosis-associated cancer in the ovary plus concurrent endometrial cancer is probably the theory there. And historically we know those patients do really well. And the third question was...
I'm going to go to Anna. Anna, I'm going to talk to you. So how do we identify those cold tumors? How do we identify, in I think the work that you've done with dostarlimab, the work that we've all done across all these trials, how are we going to identify those patients who are not going to respond to immune therapy? What's some of the work that's being done? Right now, we continue to do that. Can you touch a little bit on that?
Yeah, for sure. In a very short manner, it is a very good point. So we are about to publish a clinical cancer research when we analyze further molecular feature beyond mismatch repair state. We have already presented in ESMO 2 years ago. So in summary, you need to put together mismatch repair status, TMB, PD-L1. What we have learned is those patients who are pMMR, but they have high tumor mutation burden and CPS greater than 1, the overall response rate are equal to dMMR. However, those dMMR who are TMB low, this patient exceeds, their responses is similar to mismatch repair proficiency. So it means that we cannot stop in mismatch repair status. We need to go further and to have all the molecular features that may help us to determine what is the best therapy for our patients.
And you're going to see the molecular features of 018 and Ruby presented at a meeting soon that hopefully will also shed some light in. Even when you add chemo to checkpoint, are there still cold tumors where it's not needed?
And we're really going to face, can we eliminate chemotherapy? We've talked about radiation, but can we eliminate chemotherapy? Are there patients, to your point, right? Are there patients who are going to just need IO therapy? And we would love to, if that is the case, we would love to. Now, we're going to have to debate that because we're going to have to look at the outcomes because the control arm was just chemotherapy. I want to thank all of you who stuck it out. Thank you very much, everybody.
Thank you, everyone. David. Thank you, David.
Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/UDV860. This educational activity is supported by educational grants from Eisai Incorporated, GSK, and Merck & Company Incorporated.